Today we'll be talking about ischemic heart disease. I'm Dr. Swati Singh from the Department of Pathology. First is a general description. What are ischemic heart diseases? Ischemic heart diseases represent a group of pathophysiologically related syndromes resulting from myocardial ischemia. So there are a group of syndromes. The common cause is myocardial ischemia. What is myocardial ischemia? It is an imbalance between myocardial supply or perfusion and cardiac demand for oxygenated blood. Ischemia not only limits tissue oxygenation and thus ATP generation, but also reduces the availability of nutrients and there is a removal of metabolic wastes. In more than 90% of cases, myocardial ischemia results from reduced blood flow to the obstructive atherosclerotic lesions in the epicardial coronary arteries. Consequently, ISG is frequently referred to as coronary artery disease. Thus, ISG is often the late manifestation of coronary atherosclerosis that began during childhood or adolescence. What are the different clinical syndromes included? These are myocardial infarction, angina pectoris, chronic ischemic heart disease with heart failure, and sudden cardiac death. Myocardial infarction is where ischemia causes frank cardiac necrosis. So myocardial infarction, the cardinal feature is there is necrosis also. Angina pectoris, which is literally known as chest pain, is ischemia is not severe enough to cause infarction, but the symptoms nevertheless portend infarction risk. So there is no infarction at present, but if this persists, there can be infarction later. Then the other syndromes are chronic IID with heart failure and sudden cardiac deaths. The epidemiology. IID is the leading cause of death in the United States. 1 out of every 6 deaths in 2008, where more than 400,000 individuals were affected, and other developed nations, approximately 7 million total per year. Since peaking in 1963, the overall death rate from ISG has fallen in the United States by approximately 50%. This remarkable improvement can be attributed to preventive measures and improvement in diagnostic and therapeutic advances. Prevention is achieved by modifying the important risk factors such as smoking, blood cholesterol, and hypertension. And diagnostic and therapeutic advances have been made with more effective treatments now being available. The pathogenesis. The dominant cause of ischemic heart diseases is insufficient coronary perfusion relative to the myocardial demand. So what is the demand? It is not being met. There is insufficient coronary perfusion. In the vast majority of cases, this is due to chronic progressive atherosclerotic narrowing of the epicardial coronary arteries and variable degree of superimposed acute plaque changes. So this continues for a long period of time. There is chronic progressive atherosclerotic narrowing of the epicardial artery, and superimposed on these, there are superimposed acute plaque changes. These can be in the form of thrombosis or vasospasm. The manifestations of coronary atherosclerosis are generally due to progressive narrowing of the lumen leading to stenosis or fixed obstructions, or to acute plaque erosion or rupture with thrombosis, all of which compromise blood flow. A fixed lesion obstructing greater is known as a chronic vascular occlusion. More than 90% of patients with IIT have atherosclerosis involving one or more of the epicardial coronary arteries. The clinical 75% of the vascular cross-sectional area defines significant arterial disease. This is generally the threshold for symptomatic ischemia, which is precipitated by exercise, typically manifesting as angina. The acute plaque changes. The acute coronary syndromes are typically initiated by an unpredictable and abrupt conversion of a stable atherosclerotic plaque to an unstable and potentially life-threatening atherothrombotic lesion through rupture, superficial erosion, ulceration, fissuring, or deep hemorrhage. The plaque changes, typically associated with intralesional inflammation, precipitate the formation of a superimposed thrombus that partially or completely occludes the artery. So chronic changes have been present since long. Superimposed on these, there are acute plaque changes which partially or completely occlude the arteries. Now, the different syndromes in some greater detail. Angina pectoris is characterized by paroxysmal and usually recurrent attacks of substernal or precordial chest discomfort caused by transient, which is usually 15 seconds to 15 minutes, myocardial ischemia that is insufficient to induce myocyte necrosis. So these are recurrent attacks of chest discomfort caused by myocardial ischemia, but this ischemia is not severe enough to cause myocyte necrosis. There are three overlapping patterns of angina pectoris caused by varying combinations of decreased perfusion, increased demands, and coronary arterial pathology. These are stable or typical angina, Prinzmental or variant angina, or unstable or crescendo angina. Prinzmental or variant angina is an uncommon form of episodic myocardial ischemia. It is caused by coronary artery spasm. The angina attacks are unrelated to physical activity, heart rate, or blood pressure. Prinzmental angina generally responds promptly to vasodilators. The unstable or crescendo angina refers to a pattern of increasingly frequent, prolonged is more than 20 minutes, or severe angina or chest discomfort that is described as frank pain, precipitated by progressively lower levels of physical activity or even occurring at rest. Approximately one half of the patients with unstable angina have evidence of myocardial necrosis. For others, acute MI may be imminent. Now is myocardial infarction, which is also referred to as heart attack, is the death of cardiac muscle due to prolonged severe ischemia. So there is necrosis as a result because of ischemia. The incidence and risk factors. The myocardial infarction can occur at virtually any age. Nearly 10% of myocardial infarctions occur in people younger than 40 and 45% occur in people younger than 65. Nevertheless, MI frequently rises progressively with increasing age. Through middle age, male gender increase the relative risk of MI. Women are generally protected against MI during their reproductive years. However, postmenopausal decline in estrogen production is usually associated with increased incidence of CAD and IHD and is the most common death of women, and thus IHD is the most common cause of death in older women. The pathogenesis, coronary artery occlusion. The following sequence of event likely underlines most myocardial infarctions. A coronary artery atheromatous plaque undergoes an acute plaque change consisting of intraplaque hemorrhage, erosion or ulceration, or rupture or fissuring. When exposed to subendothelial collagen and necrotic plaque contents, platelets adhere, become activated, release their granule content, and aggregate to form microthrombi. Vasospasm is stimulated by mediators released from the platelets. Tissue factor activates the coagulation pathway, adding to the bulk of the thrombus, and within minutes the thrombus can expand to completely occlude the vessel. The myocardial response. Coronary artery obstruction diminishes blood flow to a region of the myocardium, causing ischemia, rapid myocardial dysfunction, and eventually, with prolonged vascular compromise, even myocyte death. The anatomic region supplied by that artery is referred to as the area at risk. The outcome depends predominantly on the severity and duration of the flow deprivation. The key events, the approximate time of onset of key events in ischemic cardiac myocytes. There is onset of ATP depletion within seconds. Loss of contractility of the muscle fibers occurs with loss of deprivation within less than 2 minutes. ATP is reduced to 50% of normal in 10 minutes, while it is reduced to even further 10% of normal within 40 minutes. Irreversible cell injury sets in within 20 to 40 minutes of oxygen deprivation, while macrovascular injury takes more than 1 hour to set in. The early biochemical consequence of myocardial ischemia is a cessation of aerobic metabolism within seconds, leading to inadequate production of high energy phosphates, example creatine phosphate and adenosine triphosphate, and accumulation of potentially noxious metabolites, example lactic acid. Ultrastructural changes, including myofibrillar relaxation, glycogen deprivation, and cell and mitochondrial swelling, also develop within a few minutes of the onset of ischemia. These are the early manifestations of ischemic injury, but are potentially reversible. Severe ischemia, where blood flow is less than 10% or less of normal, lasting for 20 to 30 minutes or longer, leads to irreversible damage. So an area of irreversibility sets in of cardiac myocytes. This provides a rationale for rapid diagnosis in acute MI to permit coronary intervention to establish reperfusion and salvage as much at-risk myocardium as possible. This is a diagram showing how there is progression of myocardial necrosis after coronary artery occlusion. The innermost layer is the endocardium, while the obstructive coronary artery is shown by the lumen. This shows the zone of perfusion with the area of risk. Then this area is, as irreversible injury sets in, the area of zone of necrosis sets in, and gradually with the continuing lack or lack of perfusion, this zone of necrosis finally involves most of the myocardial thickness. The patterns of infection, these can be transmural infarction, the subendocardial or non-transmural infarction, or multifocal microinfarction. Transmural infarction, the necrosis involves virtually the full thickness of the ventricular wall in the distribution of the effective coronary artery. This pattern of infarction is usually associated with a combination of chronic coronary atherosclerosis, acute plaque change, and superimposed thrombosis. Subendocardial or non-transmural infarction, a subendocardial infarct typically involving roughly the inner third of the ventricular wall, can occur as a result of a plaque disruption followed by coronary thrombus that becomes lysed, therapeutically or spontaneously, before myocardial necrosis extends across the full thickness of the wall. Multifocal microinfarction, this pattern is seen where there is pathology involving smaller intramural vessels. This is a table showing the different gross and light microscopic and electron microscopic changes that occur in the heart muscle with the advent of time. Earlier, the injury is a reversible injury for the first 1 hour, half an hour, 0 to half an hour. So there are no gross changes and no light microscopic changes. There are only electron microscopic changes in the form of relaxation of myofibrils, glycogen loss, and mitochondrial swelling. As irreversible injury sets in, for the first half an hour to 4 hours, there are no gross microscopic changes, but on light microscopically, there can be variable waviness of fiber, especially at the borders. Electron microscopic changes in the form of sacral-liminal disruption and mitochondrial amorphous densities can be present. Gross microscopic changes set in after 4 hours of continued ischemia. In the first 4 to 12 hours, there is dark mottling, or in the light microscope, there are early coagulation necrosis, edema, and hemorrhage. 12 to 24 hours, there is dark mottling, along with ongoing coagulation necrosis, pycnosis of the nuclei, myocyte hypereosinophilia, marginal contraction, band necrosis, and early neutrophilic infiltrate. First 1 to 3 days, there is mottling with yellow tan infarct center. There is coagulation necrosis with loss of nuclei and striations, breast interstitial infiltrate of neutrophils. 3 to 7 days, there is hyperemic borders, central yellow tan softening, beginning disintegration of the dense myofibers with dying neutrophils, early phagocytosis of dead cells by the macrophages at the infarct border. 7 to 10 days, there is maximally yellow tan and soft with depressed red tan borders. Well-developed phagocytes of dead cells, granulation tissue are present at the margins. The gross and microscopic appearance of an infarct depends upon the duration of the survival of the patient following the MI. Area of damage undergoes a progressive sequence of morphological changes involving typical ischemic coagulative necrosis, followed by inflammation and repair that closely parallels response to injury in other tissues. Early morphological recognition of acute MI can be difficult, particularly when death occurs within a few hours of the onset of symptoms. The histopathological changes, typical changes of coagulative necrosis become detectable in the first 6 to 12 hours. The necrotic muscle elicits acute inflammation, most prominent between 1 and 3 days. Thereafter, macrophages remove the necrotic myocytes, most noticeable by 3 to 7 days, and the damaged zone is progressively replaced by the ingrowth of highly vascularized granulation tissue, most prominent at 1 to 2 weeks. As healing progresses, this is replaced by fibrous tissue. Clinical features. MI is diagnosed by the clinical symptoms, laboratory tests for the presence of myocardial proteins in the plasma, and characteristic ECG changes. Patients with MI classically present with prolonged, which is more than 30 minutes chest pain, this which is described as crushing, stabbing or squeezing, associated with a rapid weak pulse, profuse sweating, and nausea and vomiting are also common. Dyspnea due to impaired contractility of the ischemic myocardium and the resultant pulmonary congestion and edema is a frequent symptom. The laboratory evaluation of MI is based on measuring the blood levels of proteins that leak out of irreversibly damaged myocytes. The most useful of these molecules are the cardiac specific troponins I and troponin T, and the MB fraction of creatine kinase or CKMB. The MB form of creatine kinase is sensitive but not specific, since it can also be elevated after skeletal muscle injury. To summarize, the time of elevation of CKMB, troponin T and troponin I is 3 to 12 hours post-MI, and CKMB and CTNI peak at 24 hours and troponin T levels peak somewhere between 12 to 48 hours. CKMB returns to normal in 48 to 72 hours and trop I in 5 to 10 days. The complications of myocardial ischemia are contractile dysfunction, arrhythmia, and myocardial rupture. Contractile dysfunction, some degree of left ventricular failure with hypertension, pulmonary vascular congestion, and interstitial pulmonary transudates, which can progress to pulmonary edema and respiratory impairment. Arrhythmias, myocardial irritability, and conduction disbalances following MI that lead to potentially fatal arrhythmias, and myocardial rupture. These include rupture of the ventricular free wall with hemopericardium and cardiac tamponade. Rupture of the ventricular septum, less common, leading to an acute VSD and left to right shunting. Papillary muscle rupture, resulting in the acute onset of mitral regurgitation. The complications of myocardial infarction are ventricular aneurysm, pericarditis, infarct expansion, mural thrombus, and papillary muscle dysfunction. A small word about the chronic ischemic heart diseases, which describe progressive congestive heart failure as a consequence of accumulated ischemic myocardial damage and or inadequate compensatory responses. In most instances, there has been prior MI and sometimes previous coronary arterial interventions and or bypass surgery. Morphology, chronic IRD have cardiomegaly with left ventricular hypertrophy and dilatation. Invariably, there is some degree of stenotic coronary atherosclerosis. Scars representing healed infarcts are usually present. Microscopic findings include myocardial hypertrophy, diffuse subendocardial vacuolization, and fibrosis. So, thank you.